Welcome to Parasitic Diseases. Today we're going to discuss American Trypanosomiasis, otherwise known as Chagas disease, caused by a single organism, Trypanosoma cruzi. First of all, let's see where we find Trypanosoma cruzi. We find it throughout Central and South America, with very few exceptions. This narrow little zone here is Chagas disease free. We don't find it in any of the Caribbean islands, but it is found throughout Mexico and all of the Central American countries, including all the way down into Tierra del Fuego. This is a remarkable organism with a remarkable biology and an even more remarkable vector, because this is another vector-borne infection. African trypanosomiasis, in contrast, is transmitted by a tsetse fly. It's a dipteran. It's got many species throughout West and East Africa, and they're all capable of transmitting this. The same is true for American trypanosomiasis and its vectors. Now, instead of in biting flies, they're in true bugs, the hemipterans, and it's a group of bugs known as the reduvid bugs. They have other names too, and aptly named. One of them is assassin bug because of what it does in transmitting this infection from person to person. Also known as the kissing bug, and we'll see why when we discuss how this is transmitted. And so you see throughout the distribution zone of Chagas disease, you find these vector species vary from place to place, all the way down into South America. Notice that the southern half of the United States is also colored red for certain reduvid bug species, although this is a zone in which the vector exists, but the parasite does not exist. So we can stop Chagas disease right about the midpoint of Mexico and say that we don't have Chagas disease further north than that in people. However, we do have transfusion-transmitted infection in people in the United States, and in North America, I should say. And we also have animal transmission from dog to dog, and perhaps things like coyotes and wolves as well, of transmission of this infection from animal to animal that has yet to spill over into the human population. So it's an infection that's restricted in people, at least, from the central part of South Mexico all the way down into the Pampas region of South America. Again, just noticing these distributions. These are actually very interesting bugs, and were noted early on in Darwin's travels, for instance. When he got to South America, he was invaded by reduvid bugs in the house that he stayed at while he was at Valparaiso, climbing the Andes to look at the other side to see what Brazil might look like in terms of the jungle areas. Because of the high altitude that he was at, I don't know why, but he might have presumed that he was out of harm's way, but it certainly was not the case at all. Not that he acquired Chagas disease, but he was certainly struck by the number of biting bugs that he found on his person the next morning when he woke up. The real hero of this infection is attributable to a single person, Carlos Chagas. He was a remarkable man. He worked both in city, or I should say the built environment, and rural situations. He was not only a country doctor, but also an alert person who knew what he was looking at when he saw it. In a single series of discoveries which were linked to each other, he not only discovered the cause of the disease that was later on carry his name, but he also discovered the vector species, and he discovered much of the pathology as well, and worked out the life cycle. So we see a very wonderful photograph of Carlos Chagas here, but we also see a memorial to Carlos Chagas from the country of Brazil. On one side of this 10,000 cruceros note, we find Chagas hard at work in his laboratory. And on the other side, we find a beautiful portrait of Carlos Chagas and the complete life cycle of the organism in the mammalian host. as well as in the bug itself. Quite remarkable for a country to devote the pictorial aspects of its money to telling the citizens of that country something about the public health importance of a disease, which I think virtually every Brazilian citizen knows. So this is my quote here: knowing the life cycle of Chagas disease is like money in the bank. In this case, quite literally, money in the bank. Regrettably, Carlos Chagas never was acknowledged fully for his discovery by actually receiving the Nobel Prize, but certainly he should have. His accomplishments were quite telling in terms of human health and the interruption of the life cycle. And in my view, he should have received it. So the life cycle of this parasite is a little bit different than the ones we've discussed before that involve vectors. And that's because of what happens in the vector itself. So we begin by showing reduvid bug taking a blood meal from an uninfected individual. And note that the parasites are colored this pink color. So you'll notice throughout the presentations that the parasite is easy to distinguish in these drawings by the fact that we've colorized them for you. Notice that there are no colorized parasites indicated near the biting part of this vector. And in fact, that's not how we catch this infection. It's quite unique. The vector actually sucks blood, and the abdomen then fills up with blood. And in order to make room for the blood meal, it expresses feces out of its anus, which contains the infectious form of Trypanosoma cruzi, the metacyclic trypomastigote. We don't know of any other vector species or any other infection that infects in just this manner. So it's the feces of the bug itself that contains the organisms. So how in the world could we ever become infected? Well, the answer is a very complicated one involving some of the secretions of the salivary glands of the reduvid bug and our reaction to it. As the bug takes its blood meal, it injects an anesthetic. It's very gentle in its approach, and that's why it's called the kissing bug. It gently kisses us, perhaps near the face, as we sleep in our little grass shack in the rural mountains of the Andes. And as it does so, it also injects proteins which induce eventually, as it withdraws its mouth parts, an itching sensation. And this itching sensation, which is followed by this anesthetic portion of its feeding habits, forces us to now rub the area of bite. And in doing so, inadvertently, of course, the feces of the organism of the bug is right next to where that bite wound is, and we rub it into our eye. That's all that's necessary. Once the organism gains access to the mucous membranes, it's able to penetrate those membranes and enter the blood supply. And when it does, instead of behaving like the African trypanosomes, which remain as the trypomastigote throughout its entire life cycle, this trypomastigote has a secret life that it begins by penetrating cells. And at that point, it now becomes an obligate intracellular parasite. It loses its flagellum, it rounds up, and it's indistinguishable from the Leishmania parasites that we discussed earlier. It's known as an amastigote because it does not have a flagellum any longer. And that is the replication stage for this parasite. And as we'll see, there's some interesting nuance as to how that comes about as well. But for the time being, let's just finish the life cycle, and then we'll come back to the biology. So this parasite then replicates in cells. It destroys that cell. It then moves to another cell and another cell and another cell. But if it really wants to distribute itself throughout the body and invade a variety of cells, this is not the best way to do it. The best way to do it is to revert back to a trypomastigote stage, re-enter the blood supply, travel to another portion of the body, penetrate another cell type, and begin this amastigote stage again somewhere else. So the parasite hops, skips, and jumps through our tissues. infecting heart muscle, nervous tissue. The mesenteric plexus of the large intestine and small intestine is invaded. It invades smooth muscle tissue, and it invades, essentially, it's capable of invading virtually every cell type. But it has its maximum effects in these sites, cardiac muscle and mesenteric plexus. Division goes on and cell death occurs at a rapid rate. But this is a little kid. We've depicted a little kid here for your to emphasize the fact that this infection starts out as an innocent little swelling of an eye, let's say, because that's where we rub this parasite into our eye. When the eye swells up and closes off, it's known as Romagn's sign. Carlos Chagas was well aware of this and eventually put two and two together to say, this is the beginning of the infection. But this doesn't really affect all of these other tissues in a pathological fashion until this small child has grown up to a young adult, or perhaps even an older adult, in their 30s, 40s, or 50s. And that's when the real pathology from this infection starts to manifest itself. Just to finish the life cycle first, the reduvid bug, uninfected in this case, takes blood meal from a host, and in doing so absorbs a portion of the infection as well, in this case, the trypanosomiasis stage. And then I'll show you what happens inside the bug in a moment. The cycle occurs inside the bug. It's a one-way street in the oral cavity, out the anus, to once again infect another host. Very, very, very different biology from from all other organisms. No other pathogen of humans behaves this way. Here's an up-close and personal look at the reduvid bugs. They're kind of menacing when you look at them closely. This is a feeding bug right now, and you can see the proboscis is inserted into the part of the skin of this person volunteering to have this picture taken. This is an uninfected bug, of course. And as long as the organism, as long as the bug rather feeds on this host, there's no pain whatsoever. So you might consider volunteering for this photograph if they asked you to do it. But knowing what it does, of course, is it gives one pause, nonetheless. So the assassin bug, kissing bug, vinchuca bug, as it's known in Central and South America, is the one which, as I mentioned before, Charles Darwin wrote about, and lots of other people too. Another shot of one just simply taking a blood meal, and notice how fat the abdomen gets, and very soon thereafter, the feces will start to come out. This is the kind of habitat that you can expect to find these bugs breeding in and living in. And of course, people live here too. So you've got the bugs, the people, and the animals. I should have mentioned earlier, but I will now, that Trypanosoma cruzi is capable of infecting almost all mammals. The same species can infect all mammals. And in South America, they have the highest biodiversity of mammals on the planet. You'd think that Africa would have had that, right? But it's not true. There's a region of Brazil that interfaces with the pampas of both Uruguay, Paraguay, and Argentina, which has the maximum biodiversity with regards to mammal species, including the giant armadillo, the giant anteater. All of those animals can acquire this infection by being bitten by reduvid bugs that are infected. Animals sometimes acquire the infection because they can see themselves being bitten by a reduvid bug, and they will actually eat the reduvid bug, pick it right off and eat it. And in doing so, of course, they expose their mucous membranes inside their oral cavity to the organism, and that's how they become infected. So here's just a shot of the trypanosomiasis with its large kinetoplast. In fact, it has the largest kinetoplast of all of the kinetoplastidae organisms that we've discussed. So let's delve into this organism a little bit further to show you how sinister and how successful it has evolved over the millions of years of evolution. First of all, the infection itself results in dendritic cells downregulating its IL-6, IL-12, tumor necrosis alpha, some proteins associated with the histocompatibility complex, and CD40, which is important for upregulation of immunity related to the Th1 response. Trypanosomiasis in the bloodstream also inhibit components of the cascade for complement formation. So they're unable to be killed by antibody and complement, and as a result of that, they're able to evade immune system. Trypanosoma cruzi has worked out a very, very interesting and unique way of entering a cell. It's not taken up in a parasitophorous vacuole, as most other pathogens are. I know there are a few bacterial species that can enter in a unique fashion as well. Legionella is one of those. And T. cruzi imitates some of the aspects of the entry of a Legionella organism by altering the events at the surface of the host cell prior to entering. What it ends up doing, however, is, I think, unique in the at least eukaryotic parasite world. And that is, it escapes from any attempt on the part of the host cell to develop a vacuole and penetrates directly into naked cytoplasm. When that occurs, the organism essentially disappears from the radar screen of either the innate immune responses or any of the acquired immune responses that this host cell may regulate to kill off parasites that invade it. It can't see it, it can't kill it. And here's a time-lapse photograph series showing exactly how this parasite enters. I know it's hard to make out the details here, but just take the word of the people that developed this paper and showed these frames that the parasite is actually entering naked cytoplasm. There are lots of molecules from the host and the parasite that interact to allow this to happen that have been selected over millions of years of evolutionary history, which allows the parasite, the trypanosomiasis parasite, to actually penetrate. Eventually, it rounds up, as I've mentioned before, into the amastigote stage. All of these organisms are now in naked cytoplasm. It avoids exposure to the lysosomal enzyme cascade that you might get. Let's say if you were Leishmania, which doesn't do that, right? Leishmania is taken up by a parasitophorous vacuole. They don't prevent the fusion of lysosomes. What they do is interfere with the lysosomal enzymes. This is taking the infection to the next step. Why bother with lysosomes when I don't even have to fuse with those vacuoles to begin with because I'm not in a vacuole? So that's where its life has been selected for. And now Dr. Daniel Griffin is going to give a clinical vignette illustrating the pathogenesis of this infection.
We have a 40-year-old immigrant from Brazil who had worked as a farmer, and they're reporting a 2-year history of increasing heart rate and later development of loss of consciousness. Now, this gentleman has immigrated to the United States. A year prior, he was seen by a physician with the increased heart rate, weakness, but at that point had no congestive heart failure symptoms. He had had premature ventricular contractions, PVCs. He had atrial fibrillation, atrial flutter. He was treated with an antiarrhythmic amiodarone, and he had an AICD device placed. Further history was obtained, and some diagnostic testing was performed. Now, what about clinical disease with Chagas? We have 4 types that I'm going to break this down into. We have acute Chagas disease. We have chronic Chagas disease. We also have reactivation and congenital Chagas disease. Now, acute Chagas disease. Acute Chagas disease, the incubation period is from a few days to 2 weeks before the onset of symptoms. Now, that's when the disease is acquired from the vector. But when the disease is acquired another way, such as through transfusion or transplant, the incubation period may be as long as 4 months. So we're going to see a variation there. Now, acute disease can range from non-specific symptoms such as malaise, fever, to severe manifestations. Now, some patients are reportedly asymptomatic. That probably blends in with some people who had a mild illness and they just chalk this up to one of the other many viral or other self-limiting illnesses they had. Now, what about severe acute manifestations? This is reported not to be common. It's estimated to be that maybe 1% of the exposures result in severe acute manifestations. These can be acute myocarditis, so acute inflammation of the heart, a pericardial effusion, this is fluid around the heart, and in some cases you can actually get meningoencephalitis, and this is inflammation of the meninges, the area covering the central nervous system, as well as encephalitis, which is inflammation of the brain itself. The risk of severe disease and mortality during acute disease tends to be the highest with orally acquired infection. And as Dr. Despommier brought up, not only can the reduvid bug create an entrance portal or even its feces get in through the eye, but sometimes in fruit juices or other means you can actually ingest the infectious agents. Now, what about chronic Chagas disease? Now, most patients survive the acute phase. As we mentioned, most probably don't have any notable symptoms. They then go on to enter the chronic phase. And although they may remain asymptomatic, they actually can be capable of transmitting parasites to the insect vector. During the chronic phase of Chagas disease, individuals enter what is referred to as an indeterminate or latent stage, which may continue for life for most. We'll say 70 to 80% is what we suggest. But unfortunately, some individuals will later go on to manifest with symptoms attributable to injury to the heart or to the gastrointestinal system. Now, in 20 to 30% of patients, there's a progression of the disease, and this is going to manifest as the cardiac form of Chagas or the gastrointestinal form of Chagas disease. Now, what about chronic with cardiac manifestations? Clinically, the patient can experience a number of symptoms. They can be extrasystole, so extra heartbeats. They can have enlargement of the right ventricle, the right part of the heart. They can actually eventually develop heart failure. But right bundle branch block, this is a cardiac conduction interference. That's actually typically the earliest disturbance evidence on ECG. And eventually, unfortunately, some of these individuals will have progression of cardiac disease leading to death. Now, some investigators believe that it's the conduction system disturbances that represent the most common cause of death from Chagasic heart disease, rather than the dramatic cardiomyopathy and heart failure seen in so many patients. Now, the heart failure, the enlarged heart is quite memorable, but it may actually be the cardiac conduction disturbances that are the most life-threatening and most concerning. Now, what about GI manifestations? So gastrointestinal involvement mainly manifests with the development of megaesophagus. This is the esophagus is enlarging, developing problems with dysphagia, problems with swallowing, actually regurgitation, food coming back up, and enlargement of the colon or megacolon, leading to constipation, fecal retention. Now, the pathogenesis of gastrointestinal disease involves damage to the myenteric and submucosal nerve plexus, leading to denervation and destruction and fibrosis. The development of gastrointestinal manifestations versus cardiac, so GI versus heart, may be related to a couple things. Strain differences in the parasite, and we say that because we're seeing these in different regions of the world. But there may also be different genetic backgrounds. So the reason we're seeing gastrointestinal manifestations more in Latin America, cardiac manifestations more in South America, may involve differences in the parasite. It may also involve differences in the hosts in these various regions. Now, what about reactivation Chagas disease? This is now described in patients who are immunocompromised, such as HIV, or they've been on medicines that suppress the immune system. Unfortunately, patients suffering from advanced HIV/AIDS can exhibit all the signs and symptoms of an acute phased infection, even if it's been many years since that was acquired. Left untreated, they can actually go on to develop overwhelming infection, and they can actually end up, as we described in the acute, with neurological involvement, a meningoencephalitic picture. Congenital Chagas disease. This is really something that we worry about in an acutely infected mother who's pregnant, right? And then it's going to go on to potentially transmit this to the child. It's estimated And there's a broad range here. Some say 1%, some say up to 10% of infants born to an infected mother can go on to acquire congenital Chagas disease. Transmission can also occur during chronic disease. This is much less common, but actually was documented a number of years ago in the United States. And then congenital infection can lead to acute disease, or just like the adult, you can potentially have control and then later on progress to chronic disease if there is no treatment. This shows you a few of the classic clinical features. Romagnon's sign. Now, why are people getting this? And the two ways that you can actually have the parasites enter in this sort of a situation is the break in the skin and then the feces getting in through the wound, or the sleeping individual may rub the feces into the conjunctiva. And that is felt by most of us to be what triggers Romagnonitis. You're actually rubbing bug feces with the parasites into your conjunctiva. This is the enormous megacolon, and this is a cardiomegaly seen on chest imaging. Here's that impressive heart I described. We say that we need to worry about the conduction system, but there's something quite impressive about cardiomegaly due to chronic infection with Trypanosoma cruzi. But what about diagnosis? In acute disease, the level of parasites is often high enough that the parasites can actually be detected on peripheral blood smears. This would be much like malaria, where we're going to order thick and a thin blood smear. PCR, the nucleic acid amplification testing, has greatly improved our ability to make this diagnosis, and it has greater sensitivity over the microscopic evaluation. Serology, this is how we're making most of our chronic disease diagnoses. We're looking at detection of serum IgG. There's a lot of challenges with Chagas serology, so most of the diagnostic algorithms require 2 diagnostic serology tests to be positive, and this is not a screening test. So if a person was referred to a clinician because they tried to donate blood and had a positive test, it doesn't count as a diagnostic serology. That's a screening serology. You need to go ahead and do 2 more to verify the diagnosis. And histology. In some situations, a tissue may be biopsied, and you can actually microscopically detect the parasites in the infected tissue. Here we see a wonderful peripheral blood smear. And how do you know this is Trypanosoma cruzi or Chagas? It likes to form a nice C. And that's not actually quite a joke. There actually is interesting. The other forms of trypanosomes, when they are in the blood, right, this is mainly an intracellular organism, they tend to form a nice C shape. So there's a morphology that you might see there. Now the PCR for Chagas, that is really a much better and more sensitive way to approach it, but not as visually pleasing as seeing the trypanosome in the blood smear. This is an immunofluorescent assay for Chagas disease. This is a heart biopsy, actually showing, as we mentioned, sometimes people actually progress to biopsy of the tissues where the organisms can be identified. And right bundle branch block. For those not cardiologists, one of the ways to remember, we talk about the rabbit ears in the precordial leads. Now, precordial, what do I mean by precordial? When you have had your electrocardiogram, your EKG or ECG, depending where in the world you live, they'll put a bunch of the electrodes across the front of your chest. Those are the precordial. And they are numbered, V1, 2, 3, 4, 5, 6 out to the axilla. And when you look, you actually can see these little rabbit ears that form. This is one of the 2 branches is disturbed due to infection with Chagas, and we see this as one of the earliest ECG or EKG manifestations. What about Chagas disease treatment? There's 2 main approaches that are being employed. One is benznidazole. This is for 60 days, different doses for adults and children. It's weight-based. And nifurtimox. This is 3 to 4 doses a day, and this is also for a period of time, 90 days. So this is very prolonged treatment. One of the real challenges with Chagas disease treatment is we're not certain how beneficial this is, unfortunately, despite some recent studies looking at what we thought were the highest risk groups. The second is that these are very poorly tolerated. So here's showing nifurtimox and benznidazole. Now, what about our patient? Now, our patient had an EKG that showed the right bundle branch block. He had an echocardiogram looking at the heart, and this showed a dilated left ventricle with an apical aneurysm, mild hypokinesis, and thrombosis. He had a Chagas ELISA that was positive, an immunofluorescence, which was positive, and he had a Chagas PCR that was positive. So we felt in this case that this really was a confirmed case. Patient was treated with standard heart failure regimens, an ACE inhibitor, diuretics. With his decreased heart function, he actually had his AICD. He was treated with Coumadin because he actually had this thrombus, as we note here. And treatment was attempted with benznidazole, but the patient did not tolerate a full course of the benznidazole.
Because of all the animal species in Central and South America that can harbor the infection, it would be impossible to try to get rid of them as a way of controlling the infection. That's just out of the question altogether. So instead, we can redesign our habitats to discourage the colonization of them by the reduvid bugs. And one way to do this is to realize that mud and straw houses made from bricks that you can make from quite common materials that are found throughout the environment can be replaced with other, in this case, government-subsidized materials. So that if you live in a place where you're forced to build a house out of the surroundings, the mud, the clay, the hay, the dead wood, etc., the government would step in and say, or at least the Brazilian government has stepped in and said, we can prevent Chagas disease from spreading if we can keep them out of your house. And we can construct a very simple house out of these materials, which will replace the house that you currently live in. And in doing so, we can spare you the grief of raising a family in an environment which likely will infect one or more of them. This has worked out well in some areas, and of course it's expensive, and it requires oversight, and it requires a political will. And in some countries that's present, and in others, unfortunately, it's not. Prudent use of insecticides, including DDT, for reduvid bug control has worked in some places as well. And then finally, screening blood banks for the presence of Trypanosoma cruzi using PCR has revolutionized our approach to whether or not a pint of blood is appropriate for use or has to be discarded. There's lots more to learn, of course, about this infection and about its epidemiology and about the way it affects people. And it has restricted where people live, just as African trypanosomiasis has done as well, only not on such a large scale. So the evolution and pathology of Chagas disease is nicely summarized in this, I would say, not so recent review article, but it is a rather complete article in terms of covering all of the aspects of this. Some of them have advanced since then, but it's the best review out there. So if someone out there would like to write a new one, we would welcome featuring it on our educational experience that you're now going through. We've got 2 episodes of TWIP devoted to some aspects of Trypanosoma cruzi for your listening pleasure on microbetv.tv/TWIP. And so, until next time when we'll discuss trichomoniasis, thanks for listening.